Medical College and Masters from Kasturba Medical College, Mangalore. He also did his comprehensive fellowship and long-term fellowship in cornea and refractive surgery at Arvind Eye Hospital, Madurai. And he continued working at Arvind as consultant in cataract and cornea services for the next 2 years. And later, he did his ICO fellowship at Kellogg Eye Center, Michigan, USA. And currently, he's working at Center for Sight. Welcome, sir. And over to you. Sir, are you there?
Yeah. Please stop sharing your screen. Yeah. Thank you so much. Can you see my presentation? Hello.
So your voice is little not clear.
Is it better now?
Yes.
Okay. Can you see my presentation?
Yes, the slides are visible.
Okay. Thank you for the introduction. Thank you so much. And first of all, I would like to thank Honavar sir for this opportunity. And next thing is most important, happy Janmashtami to all. Okay. So today's class is history and clinical examination of a patient with corneal diseases. It will be kind of touching all the aspects. I may not be going into details. It might be a kind of revision for you, taking small parts of everything and brushing up your knowledge about cornea. So basic outline of this class would be history. I would cover few common symptoms of corneal diseases, then typical histories of few corneal diseases. In clinical examinations, I will take you through the steps for thorough corneal examination, a quick recap about our understanding of slit lamp techniques, interpretation of various corneal signs, and lastly, I will talk about corneal drawings.
Can you
So
please increase the
symptoms,
volume?
volume is low.
Yes, sir.
Is it better now?
Little.
Mm-hmm.
Can you just move little? I think it is better now.
Better?
Little better.
Little better?
Is it the volume is maximum? I hope.
Yeah, it's maximum. I'll
Okay.
try just to put the head. Is it better now?
No, no.
Words?
Yes.
Okay. Without this. This should be fine now.
Yes, sir, better.
Better? Okay. I'll try to be louder.
Okay, sir.
Symptoms basically are visual, non-visual, or combination of both. Is it better now? The volume?
Uh, it is actually little low.
Low?
See?
Still low?
Yes. Just a minute, sir. The technical staff should be helping you out.
Yes, sir. Please carry on.
Is it fine now?
Better, sir. Please carry on.
Okay. So symptoms can be visual, non-visual, or combination. In visual symptoms, there can be sudden painful loss of vision, which can be seen in trauma or infective keratitis, corneal ulcers, herpetic infections, interstitial keratitis, or it can be a gradual painless loss of vision, which can be seen in corneal opacities, degenerations, dystrophies, or deposits on cornea. Other visual symptoms can be colored halos around lights, which is seen in mucopurulent conjunctivitis or corneal edema. In this reference, I would like to tell you about Fincham's test, which all graduate students must be knowing, which is passing a slit in front of the eye So when a slit goes in front of the eye, the colored halos due to cataract, they get broken, but the colored halos due to glaucoma or corneal edema, they are not broken. Recent onset uniocular diplopia, which is seen in corneal opacities, diminished vision in bright light, which is seen in central corneal opacities, because in bright light, your pupils constrict. Frequent change of glasses seen in keratoconus, photophobia seen in trauma to cornea, foreign body on cornea, interstitial keratitis, rupture of DM, chemical burn, or flictanular keratoconjunctivitis. These were the visual symptoms. Now we'll talk about some non-visual symptoms like dryness of eyes, grittiness of eyes, redness, which is seen mostly in trauma, pterygium, ulcers, viral keratitis, or spring catarrh. Discharge from the eyes. We see ropey discharge with spring catarrh or a bloody discharge in cases of trauma. Watering seen with trauma, foreign body, allergies, ulcers, keratitis, or lack of thalamus. Itching seen with allergic conjunctivitis, VKCs, or giant papillary conjunctivitis. Glaucoma, pterygium, and flictin, they do not cause itching until they are raised or have irregular surface. And if they are grossly raised or have irregular surface, then only they can cause itching or discomfort. Normally, they do not cause. Trachoma, if associated with large papillae or follicles, may have itching, but generally it doesn't. So all these visual symptoms, when you take history from the patient, you should mention age of onset, the progression, whether they are unilateral or bilateral, history of trauma or chemical injury, previous ocular surgery, or use of medications. Now we'll talk about next part, which is typical histories of few common corneal diseases. A patient complains of irritation of eyes, itching, burning sensation, which gets worse in windy areas or exposure to direct air of AC. The patient has dry eyes. A young boy with severe itching, pigmentation of conjunctiva, thready or ropey discharge. It suggests history of VKC, vernal keratoconjunctivitis. A computer professional complains of burning sensation, heaviness, headache at the end of the day. It suggests computer vision syndrome. We can talk about this a little more because this is commonly seen nowadays with increase in screen time. We can advise people most common and most useful rule of 20-20-20, which is after every 20 minutes, they should look at a distance of 20 feet for 20 seconds. So distance can be outside the window or another corner of the room. Other measures are having proper lighting in the room, doing eye exercises, rotating your eyes in different directions, morning and evening, taking steps for glare reduction, which can be Blu-ray or anti-glare glasses or matte finish screen guards, distance adjustment, which is 18 to 24 inches from the screen, not forgetting to blink the eyes, getting your prescription checked. These are the few steps. Another common history is patient presents that symptoms started with a minor trauma, usually a nail prick or maybe from a branch of tree. And then he complains he has pinprick pain, which usually starts early in the morning, immediately after getting up, and usually subsides in 24 hours. This suggests recurrent corneal erosions. So recurrent corneal erosions are usually it starts usually with a minor trauma, and when the patient suddenly opens his eyes in the morning, it causes an aberration, it causes erosions, and by the end of the day, they usually heal on its own. So why cornea that aberrates when the patient opens his eyes in the morning? is because of lack of hemidesmosomes, which attach epithelial cells to the basement membrane. The treatment modalities range from topical lubricants, having lubricant eye drops, gels, then hyperosmotic agents also help, bandage contact lenses, oral doxycyclines. So these are the range of treatments. Another common history, injury with wooden stick, causing redness, watering, pain, decreased vision, and whitish discoloration of a part of cornea. This suggests a fungal corneal ulcer. In this diagram, you can see feathery margins of the corneal ulcer. Patient presenting with cold, fever, sore throat, and now has acute onset pain, redness, watering, and photophobia, suggests herpetic keratitis. And a similar history, but having glare at night or blurred vision, and with redness or conjunctivitis like symptoms, adenoviral keratoconjunctivitis. 25-year-old boy with history of allergic conjunctivitis during childhood. His refraction is changing even at this age, and he suggests keratoconus. 40-year-old male complaining of glare and photophobia since long. Now the vision has decreased since few years. He may or may not complain of pain in eyes on getting up in the morning, having recurrent corneal erosions, suggests granular corneal dystrophy. 60-year-old female complaining of blurring of vision, which is more in the morning but becomes better as the day passes. It suggests Fuchs endothelial dystrophy. In this image, you can see excrescences or guttae in the endothelium, and the corneal slit, you can see the thickness is increased. So why the symptoms are more in the morning? Because patient's eyes closed the whole night. The evaporative loss from the cornea is not there. So all the edema that collects in the night, and as the day passes, the evaporation or the atmosphere causes corneal thickness to decrease. So this was about history. We covered history as symptoms which were visual and non-visual. And then we talked about common corneal diseases, how they present. Now is clinical examination. So examination of cornea starts right from the recording of vision, then torchlight examination, slit lamp examination, then special techniques like checking for corneal sensations, staining, keratometry, pachymetry, topography, corneal scraping, examination of tear film, examination of ocular adnexa, IOP, and then systemic examination. So all this includes examination of cornea. But here, I think it is about clinical examination. So let us just brush up our knowledge about slit lamp examination, and then we will talk about corneal signs and their interpretations. So as you all know, slit lamp has three parts: illumination system, observation, and mechanical support system. And when you do slit lamp examination, this is what I wanted to highlight. You should not jump directly to cornea. You should start from lid, adnexa, conjunctiva, and tear film, and then go to cornea, anterior chamber, iris, lens, and anterior vitreous. So avoid jumping directly to cornea. Look at the adnexa first. Methods of illumination are basically two types: direct illumination, indirect. Direct illumination is when you illuminate a point and observe the same point. Point of illumination is same as the point of observation. This is called parafocality, when you illuminate the same point and observe the same point. This can be adjusted by a defocus knob, which will cause loss of path focality and helps in indirect illumination. So direct illumination can be diffuse illumination, in which you use a neutral density filter and you diffusely do a gross view of anterior segment of the eye. You can pick up meibomian gland obstructions, papillae, corneal ulcers, Dellen, scars, everything you can do with the diffuse illumination. Next is direct focal, in which you do a direct illumination of a specific point. So in this image, you can see a iris nodule. Then is a parallelepiped way of illumination, in which you can see length, breadth, and depth, all three axes. This is important for examining abrasions, scars, edema, epithelium, endothelium, vascularization, and the foreign body. Next way of examination is an optical section. This is more important for localizing the depth of the lesion. This is normally done with a high magnification, and we see the depth of the lesion, how deep the lesion is in the cornea. In the first image, you can see a fragmented reflection from the corneal epithelium, suggesting an inadequate tear film or an uneven epithelial surface. The second image shows a non-reflective epithelium, thickened epithelium due to edema. The third image shows a mid-stromal deposits in the corneal stroma. First image shows the descemet membrane, which is usually non-reflective, but it is thickened and disturbed. The second image shows abnormal amount of light reflected from the endothelial layers seen in Fuch dystrophy. Third image shows central thinning in Keratoconus. Another optical sections, first image shows thinning and scar. You can notice that area of bulge is superior to the area of thinning usually seen in PMDs. Second image shows slit is thickened, shows corneal edema. The third one highlights the bullae in the cornea epithelium. Next way of illumination is conical beam, which is usually used for anterior chamber cells and flare. After direct ways of illumination of cornea or general slit lamp examination comes indirect methods, in which you illuminate one point, and from that illumination the light is reflected or scattered to the point of interest. So indirect proximal illumination, in which the area in which you illuminate the area next to the area of interest. This is most commonly used for seeing corneal nerves, scars, neovascularization of the cornea. Another way is retroillumination, in which basically you get the reflections from the back. So you can get reflections from the iris or from the fundus. So in iris retroillumination, it's basically of two types. Direct iris retroillumination, in which you illuminate the iris directly behind the pathology and you see the object or point of interest against a lighted background. In indirect iris retroillumination, you decenter the beam in such a way that iris adjacent to the corneal pathology is illuminated and you see the pathology in a dark background. So this is a good image in which you can see the area which is directly illuminating the corneal neovascularization is not so clearly visible, and the area next to it is indirectly illuminated, and the area adjacent to this is getting retroilluminated from the reflections of light from the iris. So the corneal neovascularization is best visible in this diagram in retroillumination. Next one, you can see in retroillumination against a dark background, which is indirect iris retroillumination, you can see corneal vacuoles. Next way of illumination is retroillumination, in which you see the corneal, subtle corneal opacities or scars against red illumination from the fundus. Sclerotic scatter, in which you illuminate the sclera at one limbus, the light gets total internal reflected throughout the cornea and comes out from the other limbus, other side of the limbus. But while it is getting total internally reflected in the cornea, if there is a subtle scar or edema, that will scatter the light and that opacity will become visible. So it is used to locate small corneal opacities or interstitial deposits. You can see in the diagram, sclera on one side getting illuminated, the light coming on the other side of the limbus after getting total internally reflected throughout the corneal. Another way of seeing is a specular reflection. In this method of illumination, I would highlight one important thing which you should know is that angle of incidence should be equal to angle of reflection. So you change your observation beam or tilt your observation beam and illumination beam in such a way that your angle of incidence is equal to angle of reflection. And it is most commonly used to evaluate integrity of corneal endothelium. So it highlights morphology of endothelial cells, gutters, excrescences. And last way of illumination is a tangential illumination, in which you illuminate the cornea or the iris from 90 degrees and observe at right angle. This is to localize surface pathologies. So this was brushing up our knowledge about slit lamp examination, because slit lamp is the most important way or most helpful tool for clinical examination of cornea. Next part in examination of cornea is dyes, illumination with dyes. You should know most commonly used dyes. So there are three commonly used dyes: fluorescein, next is lissamine green, third one is rose bengal. So for fluorescein, it is mostly useful for seeing epithelial defects, demarcating the epithelial defects. It also highlights filaments as seen in this image. The lower image shows double staining of a herpetic ulcer, in which the bed is stained with rose bengal stain and the edges with the fluorescein. So fluorescein, rose bengal and lissamine green, they are mostly for staining the devitalized cells, the dead cells, and mucus. So these are helpful mainly for seeing, evaluating ocular surface in dry eyes. Additional to this, rose bengal can also be used to highlight metaplastic cells in ocular surface neoplasias. So this is ocular surface in a patient of dry eye stained with rose bengal or lissamine green. Normally, you can evaluate these stain patterns in normal diffuse illumination, or you can use a red-free filter to highlight these areas in which they will appear black in color. Other examples of fluorescein staining. First one shows the epithelial defect, mucus at suture site. The last one shows a negative staining pattern, in which a raised epithelial bulla, it does not stain. So this is negative staining by fluorescein. Examination of cornea. Another important aspect is you should examine the tear film function. And most common things, most common examination tools are for clinical examination: tear meniscus height, Schirmer's test, and tear breakup time. So Schirmer's test, it tests the aqueous production, aqueous component of the tear. Schirmer's one is when you see, when you do the Schirmer's test without putting anesthetic eye drops. So it checks both basal secretion and reflex secretion. Schirmer's 2 is when you put an anesthetic eye drop, so there is no reflex tearing, so it checks only the basal production. So Schirmer's 1 is abnormal when it is less than 15 millimeter. Schirmer's 2 is abnormal when it is less than 10 millimeters. Next is tear breakup time. You put a drop of stain and then you ask the patient to close his eyes and blink if he wants to, and then open and not to blink. You observe for the first island of tear breakup appearing. If the time taken is less than 10 seconds, it is abnormal. It suggests abnormal tear quality. Tear meniscus height, you see the meniscus at the bottom and try to measure its height using the slit lamp beam. Normally it is around 0.5 millimeters. If it is less than 0.3 millimeters, it suggests aqueous deficiency. It is raised in cases of nasolacrimal duct obstructions. Another important aspect of corneal examination is checking for sensations. So you can use a esthesiometer or a wisp of cotton and check for sensations. It is always best to compare the two eyes and check for sensation in all the quadrants. Also in peripheral cornea and central cornea. So this was how we do the clinical examination of cornea. So we covered history, we covered how do we examine cornea, and now we will talk about interpretation of few corneal signs. So when we examine cornea, we can see few signs, but how do we interpret them is what we'll talk about now. Size of cornea, it can be decreased or increased. So decreased in cases of microphthalmos when it is less than 10 millimeters, megalocorneas when it is more than 13 millimeters, uh, microphthalmos when it is less than 20 millimeter of anteroposterior diameter, and bophthalmos or macrophthalmos when it is more than 33 millimeter anteroposterior diameter. Curvature of cornea can be increased in keratoconus, bophthalmos, pellucid degeneration, keratoglobus. Curvature can be decreased in microcorneas, microophthalmos, cornea plana, phthisis, hypotony, and it can be irregular due to pterygium, keratoconus, staphyloma, pellucid degeneration, ciliary staphyloma, limbal growths, post keratoplasty, glaucoma surgeries, or RD surgeries. Opacities can be due to congenital trauma, infection, inflammation, deficiencies, allergies. So any abnormality on cornea finally ends up in a opacity. Sensations can be decreased in use of local anesthetics, viral infections, leprosy, scars, degenerations, prolonged use of contact lens. This is very important. Prolonged use of contact lenses. This is what we normally miss out in history. So if sensations are used, you should operative hyperesthesia. This is also important when we do a limbal incision or in keratoplasties or when we raise a LASIK flap, we are cutting the subepithelial plexus of nerves. So this causes post-operative hyperesthesia. It takes normally 4 to 6 weeks for those nerves to regenerate. Corneal thickness can be increased in deciform keratitis, endothelial decompensation, edema, leukoma, hydrops of cornea. It can be decreased in keratoconus, bophthalmos, pellucid degeneration, Moran's ulcer, or Terrien's degeneration. Corneal vascularization. This is also another important part, another sign, important sign. Superficial vascularization is normally bright red. It is subepithelial, and the vessels grow in continuation with the conjunctival vessels. They are free, irregular, and anastomose freely, and it is usually due to conjunctival or corneal causes. So superficial vessels, they are growing from the conjunctiva on the cornea. There is a continuity of the vessels, and they are usually subepithelial or Bowman's membrane, at the level of Bowman's membrane. In contrast to this, deep vessels, they grow from the ciliary vessels in the stroma. They are at the level of stroma, purple in color, parallel, straight, and they branch dichotomously at acute angles. The causes are usually corneal or uveal. Corneal deposits can be seen in band keratopathy, tattoos, mucus plaques, KPs, Krukenberg spindle, Hudson's tally line, Fletcher ring, KF ring. So here I would like to highlight a few iron deposits in cornea. So one is Fletcher ring, which is at the level of Bowman's membrane, seen in patients of keratoconus. So this can be seen better in blue filter, cobalt blue filter. Next iron deposit is Hudson's tally line, which is at the junction of middle and lower third of cornea, usually seen in elderly. So this is usually a age-related change. Another line is Ferry's line, iron deposits at the junction of glaucoma surgery bleb. Next iron deposit is a Stocker's line, which is next to the head of the pterygium. So all these iron deposits in the cornea are because of corneal irregularity, which causes tear film or tear to stagnate, and this causes iron deposits. Kaiser Fletcher ring, KF ring. This is at the level of Descemet membrane. This is seen in Wilson's disease. This is copper deposit, which appears as brown or green. Another sign is epithelial defect, which is break in the continuity of epithelium. So can be seen in Shields ulcer, as in first image. So there are few epithelial defects in which you can give steroids. Normally, epithelial defects, you don't give steroids, you give only antibiotics, or if it is fungal, maybe antifungals. But there are few epithelial defects where you have to give steroids, and one of them is Shields ulcer, because it is in the setting of VKC. It is because of rubbing of papillae, and until you give steroids to reduce the papillae, shrink the papillae, this epithelial defect will not heal. Another similar epithelial defect which needs steroids is chemical injury. So for chemical injury epithelial defect to heal, you should give steroids. Next epithelial defect, you can see a herpetic lesion, dendritic lesion. The bottom image is a pseudomonas ulcer. You can see the mucus all around. So normally gram-negative bacilli, they spread in the cornea. Gram-positive cocci infection, they say they stay localized and usually go deep. So pseudomonas, it will cause melt of cornea and spread horizontally. So when you see epithelial defect, it can have irregular borders, which means it is a fresh injury, or it can have rounded margins or decreasing size, suggesting that it is healing. It may have dendritic borders, suggesting herpetic lesion. It may have heaped up edges, suggesting it is persistent. The staining suggests activity. Loose epithelium may be because of epithelial edema, bullae, or basement membrane cysts. Ground glass stroma is usually seen in chemical burn, and underlying infiltration is seen in infective keratitis. Plaque, mucus plaque is seen in Shields ulcer. Another sign is SPKs, superficial punctate keratopathy. They are focal areas of epithelial cell loss or disease cells. Punctate lesions, they can be coarse or fine, and they usually stain with fluorescein stain. So they can be seen in dry eyes, exposure keratopathy, viral keratitis, microsporidiosis. Microsporidiosis in the bottom image, in the first image you can see microsporidiosis. They are usually coarse SPKs and they give a stuck-on appearance. You will feel as if they are stuck on the cornea. You can do a clinical test, you can take a bud and try to remove. They will easily come out. So this suggests this hints towards microsporidiosis. Yes, you can do a gram stain to confirm microsporidial infection. Recurrent erosions, Tangential keratitis. In the bottom image, you can see usually white eye with powdery quartz deposits. Tangential keratitis responds to topical steroids, chemical injuries, graft versus host diseases, drug toxicities. So how do we interpret? If you see fine diffuse KPs, SPKs, it is due to dry eye keratoconus. Or if you see coarse raised SPKs, they are usually seen in Tangential keratitis. If you see coarse diffuse SPKs seen in herpetic infections, subepithelial infiltrates usually in epidemic keratoconjunctivitis, SPKs in the interpalpebral area usually seen with exposure, linear SPKs seen usually with rejection, epithelial rejections, lower third usually with drug toxicity, the lower third, and if they are stain positive, activity. So activity is suggested by number one, if they are stain positive, if the appearance is whitish, more of white, it suggests that they are active. If they become ground glass appearance or fading, it suggests they are becoming inactive. So activity is to be assessed because you need to give topical steroids or cyclosporin. If not there, you can manage with topical lubricants. Corneal infiltrates can be grayish, whitish, or yellowish. They are usually stromal lesions. This can be well defined or irregular. Infiltrates can be central or peripheral. You need to mention the depth of involvement, whether they are dry or moist surface, if there is any epithelial defect associated, how much is the stromal loss, and whether they are sterile or infective. So first image, you can see a ring infiltrate seen with acanthamoeba. Second image, we discussed mucus, a lot of mucinous and melt of cornea seen usually with the Pseudomonas ulcer. The next ulcer is a string of pearls or wreath-like appearance seen with nocardia infection. This image shows fungal ulcer with feathery margins with a Wesley's immune ring. So ulcers, if they are grayish or whitish, it suggests that they are sterile. If they are yellowish, infective. If margins are irregular, suggests that they are active. If margins are rounding, suggests that it's healing. If they have hyphae edges, fungal, peripheral, usually immune related, sterile, central, usually infective, and epithelial defects suggest that they are active and infective. I told you about this. If they're round, localized, and going deeper, they are usually associated with gram-positive foci. If they are large, irregular, and spreading on the surface, melting the cornea, usually with gram-negative bacilli. Red shape is nocardia. We saw in an image. Ring-shaped acanthamoeba. Radial perineuritis is also with acanthamoeba. Can be pigmented in pigmented fungal keratitis, dry looking satellite lesions with fungal. So most important thing is to differentiate whether they are sterile or infective. One we discussed is the location. If they are near limbus, tendency that they can be sterile, central, infective. Color, if it is whitish, more towards sterile. If it is yellowish, infective. Associated with epithelial defect, infective. Sterile are usually multiple. Infective, usually big ulcer, may have satellite lesions. Spread, infective spreads in all the directions, while sterile one spreads along the limbus. Surrounding cornea will be edematous and having stromal infiltrate in cases of infective. Hypopyon usually present with infective. Another sign is corneal edema, which can be epithelial or stromal. Most common causes are post-surgeries, high IOP, injury, chemical burns, contact lens, intraocular inflammation, endothelitis, or dystrophies. It can be diffuse, as seen in high IOPs, focal with injuries, instrumental touch, or focal herpetic infections. So this was about examination. We discussed about examination techniques, examination way of examining the cornea. Then we discussed about common corneal signs and their interpretations. Now the last part of the class is corneal drawings. So Sheehan started retinal drawings, and then we had an article in British Journal, a simple scheme for documenting the corneal diseases. So why do we need corneal drawings? It is for standardization of documentation, easy follow-up, teaching, and most importantly, cheaper. With anterior segment photography also available, corneal drawing does not lose its significance because it is a cheaper way of documenting. And then next important thing is you can highlight the area of interest and keep it marked in your drawings. So with the photograph, you get a diffuse photograph, but with this diagram, you can highlight the area that I want to focus on this area. This is my area of concern. So normal colors used are black color, which is for scars, degenerations, deposits, guttes. So all dystrophies and degenerations with black, sutures with black, contact lens, broken black line, foreign body with black, tissue adhesive, corneal nerves, Vogt striae, IOL. IOL is only shown in corneal slit. Blue color for epithelial edema, epithelial bullae, stromal edema, Descemet folds. Yellow for infiltrates, hypopyon, KPs. So here I would highlight pigmented KPs are brown in color, while fresh KPs you draw with yellow. Cataractus lens with yellow, Pingicula yellow, Trantas dot yellow, concretions. Green color for epithelial defect, Fluorescein stain, SPKs, Delins, vitreous. Red color for blood vessels, superficial vessels you draw in continuous with hyphema, papillae, follicles, symblepharon, pterygium, stain. Brown color, pigments, iron lines, melanosis, crooked bundles, iris, pupil, peripheral anterior synechiae. Then how to draw? You need to draw a frontal view, slit view, and a diagram for the vital stains. Big goals. Draw quadrant wise. When you draw anterior chamber details like exudates, foreign body in AC or hypopion or hyphema, do not draw on the frontal diagram. Draw in the slit diagram. Depict the side slit on the frontal view. So when you draw a frontal view, you mark the site where the site of which you are showing a slit. You should always mention area of thinning in percentage. When you draw epithelial defect or stromal infiltrate, you should always write the measurements. So epithelial defect, you should write the maximum diameter and then a diameter perpendicular to the maximum diameter. Similarly for stromal infiltrate. So when you have to mark for epithelial defect, you first stain the cornea, see the green fluorescein marking, and then make the epithelial defect. And before making the epithelial defect, see with the diffuse illumination without stain and draw the stromal infiltrate. So stromal infiltrate, you first see without staining and draw it, and then stain, and then see and draw the epithelial defect. This is a corneal scar, and you should show the corneal scar with the black color. The density of the scar is proportional to the density of shading that you do. Then vessels, new vascularization with the red color. Corneal ulcer, you show a stromal infiltrate with yellow, epithelial defect with green, surrounding edema with blue, circumciliary congestion with red, and a hypopion. You should always mention thinning of the cornea, measurements of epithelial defect and stromal infiltrate, and also height of hypopion in millimeters. This is a failed graft. See, corneal edema with blue, DM folds with blue, bulle with blue, cataractus lens with yellow, and you should show the depth of involvement. You should always mark the site of the slit. So mark in the frontal diagram where you are drawing the slit and then draw a slit diagram. Perforated corneal ulcer, again similar things, circumciliary congestion, epithelial defect, stromal infiltrate. So I want to highlight here, epithelial defect should be made after examining with the stain. You first draw the stromal infiltrate, stain, and then see and draw the epithelial defect. So here perforation we have drawn with the green color and then brown color iris plugging the perforation. Stromal infiltrate with thinning with yellow. Site of perforation where iris is plugging in with the brown. New vascularization with red. So mention the percentage of thinning and depth of stromal infiltrate. So in this diagram, you see corneal edema, corneal decompensation, full thickness edema with few bulle and DM folds, but there is no mention of lens status in the slit diagram. You should not forget to mark the lens status, whether it is cataractus or a ECIL. ECIL with black, cataractus lens with yellow. So this finishes our class. For brushing up, we'll do few MCQs. Which of the following would you evaluate using a diffuse beam? So Dylan,
Harshini and Diksha, you can take the questions.
Exenfeld loop, concretions, SPKs, Krukenberg spindle with a diffuse beam. So when you do a diffuse illumination, concretions, Adnexal things are clearly visible, and even the Dylan. For other things, parallelepiped way of illumination would be better. Guttata are depressions of endothelium due to loss of cells. So which way of illumination? I think everyone knows it is specular. Which structures can't be evaluated with the optic section? So cornea to determine the depth of lesion, cornea to determine the health of endothelium, angle estimation, anterior chamber evaluation, or lens. So optic section, I told you, it is for seeing the cross section or seeing the depth of evaluation. So second option, cornea to determine the health of endothelium, it is with the specular and not with the optic section. Next is a 30-year-old male presenting with injury, complaining of pain, photophobia, redness, mostly is fungal corneal ulcer. Band keratopathy is due to calcium deposits. Dense scar with incarceration of irises, adherent glaucoma. Corneal sensations are diminished in herpes simplex. 10-year-old boy complaining of itching, round plantar spots at the limbus, mucopurulent ropey discharge with spring catarrh. Viral epidemic keratoconjunctivitis, there is usually excessive watery lacrimation. And Herbert's rosettes are mostly with active trachoma. In trachoma, the patient is infectious when there is follicles and papillae in the palpebral conjunctiva. Other signs are signs of late stages or healing. A female patient with history of contact lens wear, suggesting complaining of redness, lacrimation, foreign body sensation. The expected diagnosis is giant papillary conjunctivitis. Sure diagnostic sign of ulcer is positive fluorescein test. If you have an epithelial defect, it suggests that it is active. Blood vessels in trachoma patient pannus lies between Bowman's and epithelium. Flesher ring, we talked about iron deposits in the cornea. So Flesher ring is the deposit in keratoconus. Which condition would you evaluate using high magnification, high illumination, and specular? It is Guttata. And ciliary injection is not seen in catarrh conjunctivitis. It is seen in iridocyclitis, ulcers, and keratitis. So, thank you so much. Thank you, sir. If you have any doubts, you can come up with the doubts.
Thank you so much, sir. After listening to your class, I think we can improvise on our interpretation as well as representation as well.
Yeah, very nicely done. Yeah, very, very good, very comprehensive. There are a lot of questions, I think, on YouTube.
Yes.
There are a lot of questions.
Yes, sir. I'll take the questions. The first question is, any specific difference in history of herpes simplex keratitis and herpes zoster ophthalmicus?
History-wise, I don't think there is much difference, but yeah, clinical signs would be herpes simplex has dendritic lesions with knobbed edges. Herpes zoster has pseudodendrites, which has tapering edges. Herpes zoster may be associated with skin lesions on one side of the face, the vesicular lesions. History-wise, I think there is not much difference. Will be similar viral history.
Okay, sir. Thank you. Next question is, how to check for the corneal sensations in terms of patient positioning and the technique?
Corneal sensations, when you use a wisp of cotton, So most important thing is the patient should not be seeing your hand. So when you do it from the side. So you should engage the patient in talk, or maybe ask them to focus at some other point and bring it from a side. The patient should not be seeing the cotton coming or your hand coming and then check the sensations. So sometimes what I usually do is make the patient look left and touch on the right side and see. Make the patient look on right and touch on the left side and see. So make the patient look on the opposite side. That way he's not seeing your hand coming, and just touch and see. Another important thing which we highlighted is comparing on two sides. You should always compare on both the sides. Yes.
Okay, sir. The next question is, can SPK be present after some mechanical injury, like with the injury with sand?
Injury with sand?
Sand, yes. Sand particle.
Hand?
Sand, sir.
Oh,
Sand
hand.
particles.
I don't think so. I don't think. Maybe if sand caused some infection, maybe, but not because of injury. Mechanically, SPKs are not seen. SPK causes are viral, toxic, dry eyes, microsporidial, which we already discussed.
Okay, sir. So next question is, what is the difference between FDDT and the tear meniscus test?
FD?
Fluorescein dye disappearance test and the tear meniscus test.
Fluorescein dye disappearance is you put fluorescein in the lower conjunctival sac and see for the presence of fluorescein after 5 minutes. If the fluorescein is still present in the conjunctival sac, it suggests blockage of nasolacrimal system. And tear meniscus is just looking at the lower meniscus height of the tear film, which is normally 0.5 millimeter. If it is less than 0.3, it suggests dry eyes. If it is more than 0.5, it suggests obstruction in nasolacrimal duct system.
Yes, sir. The next is, why and how does direct air of AC cause dry eye?
Direct air, it is mainly because I think evaporative loss, direct air of AC or direct cooler or something, it causes evaporative loss, and that is why it even if when we are sitting in front of AC, you feel like blinking because it is. I guess that answers the question. Evaporative loss.
Uh, what is the importance of checking corneal sensations in a ptosis patient, or
You know,
how to check the corneal sensations in the ptosis patient, rather importance of checking the corneal sensations in ptosis cases?
ptosis patient. I think the other nerves are normal. You need a normal trigeminal nerve for corneal sensations, so which is normal in ptosis patient. So I think it is no different than other patient. You may have to lift the eyelid a little bit and then check it. I think importance of checking is same as checking the integrating of fifth cranial nerve when you have ptosis, which can be due to other involvement of cranial nerves. Yeah.
Yes, sir. Uh, does any of the panelists have some questions? Harshini and Diksha, do you want to ask anything? If no, that's it, sir. Thank you for an excellent session.
Okay.
Thank you so much,
Thank
Lakshey.
you, Santosh sir. Thank you.
Thank you so much. So that's it for today. And on Friday, we have Dr. Ashish Bansal speaking on clinical signs and symptoms of corneal diseases. That will be an interactive talk. Thank you so much. Good night.